Thank you very much, Atul. Thank you for a nice introduction and for having me again. I think I've been here almost every year, except the one where I missed my plane. So I think that's probably why you set it up as a TC. Thank you to the audience, though I can't see you, but I hope you are at least 10 out there. I find this a bit awkward sitting here, talking to you like this. I am afraid that I may be a bit boring because I don't get the adrenaline rush from seeing you and hearing you and feeling you. Personally, I think it's a bit boring sitting here alone in my home with nobody else. I can't look at you and get the report from you. I have to stare at a small green lamp to get eye contact. Actually, X Factor tried the same a couple of weeks ago. We have X Factor from you, and they tried to run X Factor without an audience, and that didn't go well because the performers didn't really get the excitement needed. Well, anyway, let's try it and see how it goes. Let me first introduce what I'm going to talk about. The center of stage is the infant, the young child. And I want to discuss the question, the very famous question, to wheeze or not to wheeze. That is not the question. You all know the Shakespeare play Hamlet at Elsinore. What you probably didn't know was that Hamlet had asthma, pretty severe asthma. So one day he was running up the stairs and ended up by, oh, now I'm getting messages here. I don't know why. He was running up the stairs and ended up coughing his lungs out, coughing. And at that point, he made the famous exclamation, to wheeze or not to wheeze is not the question, because he was coughing. And that is the message I want to discuss with you today. What is the evidence behind wheeze or no wheeze?
Professor, terribly sorry to interrupt. It does appear as though we can't see your slideshow currently. Okay. Perhaps we could just take a look at the Zoom app. If you alt and tab and get back to the Zoom app, and then there should be a little green icon at the bottom that says share screen. If you just click that, and then your PowerPoint or Keynote should appear in front of you. Click the icon that you'd like us to see, and then click share. If you're struggling though, do let me know. I have a copy of your PowerPoint here. Oh, I think we may have just lost him for a moment. He's coming back.
Is that better?
Not at the moment. I'll tell you what we'll do. If you just stand by, I will stream you your own presentation and then hand you. Oh, no, that's better. Yes, we can see it now.
Is it better?
Yes, not bad. If you now, so we can see your screen. So if you go to the PowerPoint behind that window.
Yeah. Problem here seems to be that it's launching very slowly.
That's okay. That's it. If you just click your PowerPoint.
Sure.
That's right. And then full screen it. Marvelous. Now we can see everything. Please continue.
Okay. Sorry about that. Don't know what happened. Anyway, just to repeat, Hamlet at Elsinore had asthma, and he was running up the stairs and ended up by coughing his lungs out, and then he exclaimed, to wheeze or not to wheeze? That is not the question. So let me examine the evidence behind that statement and first introduce you to the patient, the young child, like that one. Can you see it? Ask two doctors for the diagnosis, and here you go. This slide I picked up or built over time when I was traveling around the world, and every country had its own term for this child: transient early wheeze, infantile asthma, happy wheezes, spastic bronchitis, etc., etc. In Denmark, it's typical to call it asthmatic bronchitis. They don't have that disease in Sweden. They have obstructive bronchitis, which we never see here. So it's a total confusion, and that suddenly adds to the problem of treating these children correctly. It's a very common problem. What we call troublesome lung symptoms, without mentioning wheeze, is highly common all over the westernized world. This is a study we did where we, by telephone, interviewed some 9,000, 10,000 families where we knew they had children within 2 to 5 years of age. Through that telephone interview, we identified the population of 2,700 who were reporting that the child had recurrent troublesome lung symptoms: cough, wheeze, breathlessness, whatever, but recurrent to an extent that led them to a doctor to be treated or to at least have a diagnosis. Now that was 27% in the US, 29% in Northern Europe, and 40% in Southern Europe. Moreover, the differences between the US and Europe, Northern and Southern Europe, were quite amazing, with a prevalence of 19% in Northern Europe and 30% in Southern Europe. With recurrent or common visits to the general practitioner of 46% in Southern Europe, 31% in Northern Europe. Asthma diagnosed in 12% South, 26% North. Regular steroid in 7% South, 4% North. And intermittent steroids, 10% South and 2% in the North. The main difference in the use of antihistamine, probably ketotifen, was between US, 8% were treated with ketotifen and only 1% in Northern Europe. So really, there's a heterogeneity of symptom reporting, of diagnosing, and of treatment differences that are quite significant, and reflecting the lack of agreement between doctors. Now, why is it that these young children have TROLS? Well, first, they have increased airway reactivity. That has been shown with squeeze jacket methods, where you do lung function spirometry and the methylcolonic challenge, and we've shown that children who later develop recurrent TROLS or recurrent lung symptoms have airway reactivity that is much more increased than the controls. Secondly, these young children have more airway infections, many more actually. So somehow they must have a local immune defense that is less effective. And finally, Professor's law, saying that if you change the radius of a tube, the resistance go up with the power of 4. So small changes cause a very high increase in resistance to the power of 4, and therefore has a greater effect in small airways than in large airways. That may be part of the explanation. So those three are probably the mechanisms of these very common recurrent TROLS. Excuse me for calling it TROLS from here. I believe this population is grossly undertreated, and there are very good reasons for that. First, as I alluded to, we have very ambiguous medical definitions. There's no agreement to how to define the young child suffering from recurrent symptoms, lung symptoms. There are really no specific symptoms. Wheeze could be one, breathlessness another, cough another, but it's really unspecific. We have no objective measurements. I mean, we can in the lab, we can do lung function tests, airway resistance and spirometry, but it's not in clinical practice, and it will never come. Cannot even do nitric oxide. It will not come into the clinic. Symptoms, and that's probably one of the biggest problems, symptoms are highly variable, often leading to a child being brought to the doctor. He listens with his stethoscope, he hears nothing, and he says, it's all good. And the night before and the night after, the child has been coughing all night. So typically what I'm telling parents is I'm not listening to the lungs, because it's highly unlikely that when I see him here in my clinic, not acute of course, but here in my clinic, there won't be anything I can listen to. But I'm listening to you, the parents. I think parents are the most important tool to identify patients who are in trouble and who need treatment. Problem is also you don't get a history from the child, so you have a patient who don't report symptoms, therefore relying on secondhand symptom reports. So it's not the patient, it's the parent observing, parents being able to identify symptoms reasonably and to report it to a doctor who's able to listen to the parents. And then the doctor has to define the severity and decide on treatment. So there are very many links that will lead to, most likely, on the treatment. The last one, not least, being we don't have a common language. I mean, somebody says wheeze, some of us don't believe in wheeze. So these are 7 different arguments why I think it's highly likely that children are undertreated. And at least it's a very difficult clinical area to manage. Let's look at the guidelines. Will they help us? Well, I'm very familiar with the GINA guidelines, and I've taken out a couple of points here to show you. Recurrent wheeze, they keep calling it, recurrent wheeze occurs in a large population of children 5 years and younger, typically with viral upper respiratory tract infection. That's the statement. Secondly, it's stated that not all wheezing indicates asthma. So not only is asthma described by wheezing, but also wheezing does not indicate asthma. Now here's a problem, I think, and it's not said anywhere in the guideline. Which other diseases should we consider that could cause wheezing if it's under asthma? A large population of wheezing episodes in young children is virally induced, whether the child has asthma or not. So again, stating that wheezing is not the same as asthma, without telling us what is it then. So I don't think I'm not learning a whole lot from the guidelines. And let me return to the term wheeze. To my mind, it's a misnomer. There are a few good studies here from the UK. One by Paed compared the parents and clinical findings in 139 children who were reported to wheeze, and less than 50% agreed between parents and clinicians that this was wheeze. So there's clearly no agreement between clinicians and parents. And yet, doctors are depending on parents to report wheeze. That's the definition according to guidelines. He then did another study a year after showing video clips of children who by the pediatricians were defined as wheezers, and only 59% of the parents could identify that as wheeze. So very clearly, wheeze is not well communicated and well understood between clinicians and doctors. We did a post hoc analysis, a secondary analysis in a cohort, in a clinical study we had performed. We've studied montelukast versus placebo in 689 children, 2 to 5 years of age. They were followed for 1 year, 12 months, with daily diary cards. In total, we have some 51,000 daily recordings of symptoms in the children. These children had, during the study, 235 exacerbations as defined by use of rescue oral corticosteroid, acute visits to the doctor or emergency room, or hospitalization, meaning, in my mind, relatively severe exacerbations, 235. Then we look back at the symptom recordings the days prior to these exacerbations, and we could identify that wheeze was significantly associated with a coming exacerbation, but only with an odds ratio of 2. Likewise, breathlessness was also associated with an upcoming exacerbation, but only with an odds ratio of 2. Cough had an odds ratio of 10, and using any of the above, identifying any of the symptoms above in the days before the exacerbation had an odds ratio of 14. So I think that's a very good argument not to stick with one term such as wheeze, but really include all troublesome lung symptoms in the children for identifying an upcoming exacerbation, and therefore also for identifying, is this an asthmatic child? Is this one that might benefit from treatment with anti-asthmatics? That is what we're doing at our clinic in Kopsak. We follow this regime of identifying children who have recurrent troublesome lung symptoms, whether it's cough and or noisy breathing and or shortness of breath, whatever that is really troublesome to the child and is recurrent. In those children, we put them on inhaled corticosteroid for a trial period of 3 months, and then we stop the treatment. And the criteria is that the children should be improving on steroids and should relapse when you stop treatment. If they relapse on the steroid treatment, I feel pretty confident that it has to be asthma. And why is that? Well, inhaled steroids is proven treatment for asthma and for no other disease. So I cannot see why a disorder that is improving on steroid and relapsing with no steroid shouldn't be asthma. I think that's a very simple definition. So basing it on recurrent troublesome symptoms and seeing an effect of steroids, to me, is the definition of a young child who needs treatment and totally independent of whether you can identify wheeze or not. Not only is wheeze a misnomer, but the term viral wheeze is twice a misnomer. Viral is part of the picture, but not all. And I'm going to show you data to prove that point. That is from our cohort, the older one. We just completed the 18-year visit with a 92% follow-up. So we have a very close and good adherence. We follow them closely. And we have another one of 700. And the protocol in the first 3 years of life is that we have 14 scheduled visits, and they come every time they have acute symptoms. They fill in daily diary cards, and any diagnosis, any treatment are made by pediatricians at our clinic, not by other doctors, because of this heterogeneity in diagnosis and treatment. We don't trust other doctors to be able to put a consistent diagnosis and treatment. So we control everything. They come to us if they have acute exacerbations. And as I said before, we have a very good follow-up rate that is actually very impressive. Now, when we looked at these wheezy episodes where they came to us and we did a tracheal suction or hypopharyngeal suction, we can identify virus and see the association to these episodes with an odds ratio of 3. So virus was associated with wheezy episodes, exacerbations, with an odds ratio of 3. We then looked at the bacteria and saw the same odds ratio, exactly the same odds ratio of 3. So a child who was identified with virus was associated with the exacerbation, and the exacerbations was equally associated with a child who had bacteria in the airways. That's typically Haemophilus, Moraxella, or pneumococci. So in this study, we showed that there is virus is certainly associated, but equally bacteria are associated with exacerbations. We then went further and looked at the diary cards 30 days before and 30 days after the exacerbation. So on this diagram, 0 is the time point when they came to the clinic with an exacerbation, and then you see the symptom scores 30 days before and then 30 days after. In those children who only had bacteria, the red line, those who only had virus, the blue line, those who had both, the yellow line, and they are totally superimposed. So whether the child has virus only or bacteria or both, it presents totally the same clinical picture. Just to prove the point that viral wheeze is a misnomer, it should equally be bacterial wheeze, and then it should not be wheeze at all. So it's all very, very misleading. Indeed, when I started out as a clinical researcher, I thought it was very, very difficult because everything was so inconsistent. Today, I think there is a consistent explanation, but it's not out there yet. The last point I want to make builds on these data, the identification of bacteria, and identifying bacteria as an association with these exacerbations naturally lead to the idea that maybe antibiotics may play a role as a complementary treatment to exacerbations. Bisgaard from the US published in 2015 in JAMA a double-blind randomized controlled trial where they included 607 children 1 to 6 years of age and treated them in 937 episodes, exacerbations, and the treatment was actually initiated by the parents. So in this study, the parents had been given antibiotic to have a home and start that treatment if the child had a severe exacerbation. The endpoint was how often the child needed to come for treatment with oral steroids. Pretty tough, pretty specific endpoint. If a child has an exacerbation that needs oral treatment, well. And they showed that the use of antibiotics given by the parents had an odds ratio or hazard ratio of 0.6, meaning a reduction of 1/3 of the exacerbations. Strong data. We did a similar study published in Lancet Resp, again with children with recurrent, persistent wheeze, asthma, whatever term we should use today, TROLS. We randomized them at every episode when they came to the clinic. 72 children were randomized for 148 wheezy episodes. The mean age was 2.2 years. We had instructed the parents to follow the diary cards, and when they had more than 3 days or 3 days or more of symptoms, recurrent TROLS, recurrent troublesome symptoms, they should come to the clinic, and they did. So it was not defined by any wheezing or other specific, but back to what I've said before, it was recurrent troublesome lung symptoms for 3 consecutive days. We excluded anything that could be suspicious for pneumonia, any clinical signs, any CRP which was raised, any tachypnea, any running, any high fever. They were excluded from this study. So it's basically children with no obvious sign of pneumonia, which I would define as a group of children with asthma exacerbations. We did hypopharyngeal suctions for the bacteria I mentioned, and we did PCR for the main respiratory viruses. The primary endpoint was highly significant, and it's shown to you to the right. We were able to reduce the duration of episodes with 63%, pretty much the same as they had found in the US, a 1/3 reduction in your endpoint. Reduced beta-2 agonist by 22%, both supporting that there is a clinically significant effect. It's shown to you on the graph to the right. On the x-axis, you have symptom days after intervention. So 0 is the day you start intervention. And on the y-axis, you have the number of patients or percentage of patients who have symptoms, naturally starting with 100% at 0, because that's when they were given the treatment, and tapering off over time. The red line is the placebo group, the blue line is the antibiotic group, and you see the difference in the mean duration of symptoms reduces from 7.7 to 3.4. Clinically meaningful effect, not only statistically, but clinically very meaningful effect to treat patients with severe exacerbations with antibiotics. So that's part of our clinic today, and I would say it's very successful. Not to give it to everybody, but it's very successful in severe exacerbations to give it independent of what you find, because you may not identify the bacteria. So that's our practice. This has been criticized by reflex, by many wondering about resistance. I would say to that, if I have a child of 2 years who have a severe exacerbations on the way to the hospital, I don't hesitate to use antibiotics, but I would be hesitant to treat a sore throat in an adult with antibiotics, symptoms of urinary infection in a pregnant woman, etc. There are many other places where you could reduce the use of antibiotics, but not in these children. We have a technique where we put a filter paper into the nose of young children. We measure the epithelial lining fluid from that filter in a mesoscale system to identify the cytokines and chemokines in the airways. We did that in the antibiotic study, and we identified interferon gamma, TNF-alpha, and CCL22 as closely related to the treatment effect. So if we take, for example, interferon gamma, you look at the graph. On the x-axis, you have the concentration with high concentrations to the right and low concentrations to the left. On the y-axis, you have the treatment effect, 10 days at the top. You had a 10-day reduction of symptoms, meaning that those who had low levels of interferon gamma in the epithelial lining fluid had the most benefit of a treatment. And the other way around, those who had high levels of interferon gamma were able to raise an immune response with high levels of interferon gamma. They had no effect from antibiotics. Likewise, for the other cytokines, for example, TNF-alpha, again, if you are able to mount a high response of these cytokines, you don't need antibiotics. But if you're not able to mount this response in these key cytokines, you really do benefit the most from having a treatment with antibiotics. So let me summarize. I think I've come to the end of my time. Wheeze is rarely recognized even during exacerbations. Problem is, if you don't hear anything with your stethoscope, you know nothing. It's a highly variable disease. Sometimes you hear something, sometimes you don't. And if you don't, you know absolutely nothing. It's very common here in my country that parents bring their young child to the doctor who listens with the stethoscope, hears nothing, don't listen to the parents, and send the child home. That is nothing to be proud of. I have tried to show you evidence to the fact that it's preferable to use the totality of symptoms rather than emphasize wheeze. Wheeze is not closely related to the disease, and if you wait for the child to wheeze, you come in very late. Viral is only half the truth. Both bacteria and virus are associated with exacerbations equally. So it may be a viral cause or it may be a bacterial cause. And therefore, you may benefit from treating at least the severe cases with antibiotics. Because Azitromycin, as we used, reduces symptom load during exacerbations by half. And very interesting, if you're unable to mount an appropriate immune response, for example, with TNF-alpha and interleukin 10, you benefit the most from antibiotics. So these cytokines may be used for point of care. In the near future, I believe that we can use this filter paper and mesoscale to identify how is this child's immune response and therefore decide should he have antibiotics or not. So the real question is to treat or not to treat. That is the question. Thank you very much.
Thank you very much, Hans, for the excellent presentation and overview. We are happy to take questions now. Please type in your question in Q&A section. I've got a question from Richard. Could it be that azithromycin is helping not because of antibacterial effects, but because of anti-inflammatory properties?
It's a good question and an important one. There are in vitro and animal models who've shown an anti-inflammatory effect of azithromycin. That's absolutely correct. And it could be that part of azithromycin. Why did we choose then? Well, if you want to prove a concept, you want to do everything possible and not limit the concept anyway. Therefore, we chose azithromycin, very well knowing the possible anti-inflammatory effect. I hope somebody will follow up and do a study with amoxicillin or similar to see if it's really an anti-inflammatory or antibacterial effect. But the question is very relevant.
Thanks, Hans. Any endotyping, eosinophilic versus neutrophilic in your group in children with a good response to antibiotics?
Didn't find any systemic difference. We were not able to identify the person who, or the child who needed treatment, neither from neutrophilics or from CRP or any other. The only thing that identified was the cytokine response in the epithelial lining fluid. Actually, this is a person in question, Atul, and we did a lot of many exercises to see if we could endotype the child who were responsive or not. We looked at the genotype, microbiome in the gut. We looked at the metabolome. We haven't been able to endotype these children.
Thanks, Hans. So, for practical question, somebody who is working in secondary care, how would you practically decide which children should have antibiotics?
From severity. Banal symptoms that can be treated with beta-2 agonists shouldn't have it. But if you are approaching a situation where you would consider, for example, oral steroid, that's the child where I would give it. Of course, the problem is, I mean, in clinics, you cannot put straight black and white definitions. And it's particularly difficult when you explain to parents, because they ask the same question as you do: when should we use it? And I mean, there are no strict definitions, but severity is the basis. Severity.
Thanks. Again, on similar theme by Mahesh Babu from Singapore, any differences in upper respiratory signs and symptoms between the viral and bacterial infections?
Yeah, that's important. I mean, there are no clinical ways to separate bacterial symptoms from viral symptoms. None whatsoever. None.
And do you think, is there a role of very low dose in steroids instead of azithromycin?
Low dose of inhaled steroids?
Inhaled steroid, yes.
I presume all these children will be on inhaled steroids. I would only consider this if we have a child who has been decided to have a severity that deserves regular normal dose inhaled steroids. Those who don't have that, well, on the first occasion, probably yes. But what we've done is only looking at children who are on inhaled corticosteroids. They're the only ones who've been treated.
And when
probably because we have a very low threshold for putting children on inhaled steroids.
And when they're unwell, do you give them oral steroids or azithromycin, or both of them?
Both.
Brilliant. Thank you very much, Hans, for the excellent talk.
Thank you.
We will see you next year.
So, thank you for having me.
Okay, thank you.